we are sitting at the precipice of what's been termed the fourth industrial revolution, which will be characterized by cyber-physical systems, or systems which can interact with the environment and learn from them and take in data and respond to the world in physical ways. The technology and the technological systems that we are building now will shape that future, and we are making decisions actively now that will create that. So the future isn't out there inevitably waiting to happen. We're building it.
Hello. I'm Dr. Shetty. Welcome to the Future Health Podcast. This is a podcast about the way we work, the work we do, and how technology will influence the future of work in New South Wales Health and the healthcare industry as a whole. Our guest today is Dr. Amy McLennan, Research Fellow at the 3A Institute at the ANU. I look forward to discussing her about the challenges of adopting AI in the delivery of healthcare in the future. Hello and welcome to the Future of Health podcast series. Today with me, I have Amy McLennan. Amy, would you be happy to share your background with us?
Sure. So my name is Amy McLennan. I am currently based at the 3A Institute at the Australian National University, but I didn't really start here. So I tell you a bit about my background. I grew up in the Adelaide Hills. I went to Flinders University to study medical science, and at that point I was really convinced that I was interested in practicing medicine. And I went on from there to Adelaide University, where I did my honours in anatomical sciences. And I spent a lot of time studying sports injuries, and especially injuries of the groin region in the body, which was somewhere that was pretty understudied at the time. And I became really interested in these areas of medicine that were less studied, particularly because they were stigmatized or because we had less interest in them, maybe culturally. I wasn't sure where I wanted to go from there, so I went out into the world and worked in the South Australian government in policy making, and at the time was working between the Royal College of Surgeons, the South Australian government, and funding bodies to introduce one of the first robotic surgery systems in South Australia, and that was in 2005. And as I worked into that space and then following that into international development consulting, one of the things I really learned was that science, and medical science in particular, worked really well in a lab. And the further you got away from the lab into policy making or into community development and community health, the less well science seemed to work. And at the advice of one of my mentors at the time, I took a U-turn and went and studied medical anthropology at the University of Oxford. And medical anthropology, I suppose, is the social side of health and medicine. And the course was really focused on bringing together the social and cultural aspects of human life with the medical and medical science aspects. And then as well, a certain amount of technology, because of course, technologies are really central to the way we practice healthcare and medicine. And I stayed at the University of Oxford for 10 years. I studied a master's there. I studied a PhD funded by a John Monash scholarship from Australia. And I stayed on doing a postdoctoral piece of work looking at obesity and obesity emergence and the political and economic drivers that sat underneath that. And at the time, I found myself saying a lot, well, policymakers really ought to do blah. And I realized that it had been a long time since I'd been working in the policy space, and I really wasn't necessarily the best qualified person to be recommending policy decisions at all. So I came back to Australia to work in the Department of Prime Minister and Cabinet, where I spent a couple of years working on really complex, thorny, cross-agency policy challenges, some of the biggest ones at the time. And I would have happily stayed there. I loved the job. I loved the people I worked with. And the work was incredibly challenging and also rewarding because it's an opportunity to shape the future of the nation. And a friend called me one day and said, look, there's this project happening at the ANU, and the woman running it is by the name of Genevieve Bell, and I think you'd really get along. And I ended up coming and running one of the launch workshops for the Institute, and ended up then moving over here to work on questions around the future of artificial intelligence and technology and the way they are shaping humanity and society.
Wow, what a journey. Did you work overseas as well in the meantime sometime? I was reading some work around here now.
I did. I did. So my doctoral research in particular was based on the Republic of Nauru. When I started my doctoral research, I had a strong background in nutritional science and medicine. And at the time, the research group that I was working with in the UK had just started a research agenda around obesity. And at the time, Nauru had the dubious honour of being the world's fattest nation, and that was attributed to lifestyle change. And a lot of my study at the time focused on working with the people of Nauru to understand how lifestyles had changed and how that might have changed health outcomes in the nation.
Wow, you seem to have such a great experience in humanities and the transitions, and then now working in the space of AI and technologies. In the last 20 years of being in and out of Australia, have you seen any drastic changes in that area? Or what have you noticed when you first was here in South Australia in the policies and then back in the centre? Did you see any changes of note you'd like to discuss?
Gosh, look, one of the big things for me starting in the world of AI and related technologies was, for me personally, I didn't realize how much was going on in that space. It had never occurred to me that it was a field that I could have anything to do with. So my return to Australia coincided with a whole world of new thinking, but I don't think that was new thinking to Australia. I think that was new thinking to me, if that makes sense. I think for me, being overseas and being able to see comparatively what was going on in Australia versus the rest of the world, is there are many things going on in Australia that I'm really proud of, or that we're really lucky to have, whether it's the health system we have or whether it's the kind of political environment we have. They may not be perfect, but they're a lot better than a lot of the places I've had the privilege of working or living, and for that I'm really quite thankful.
When you talk about AI and the work you're doing, can you elaborate a bit more the kind of work you're doing in that space at the moment?
Sure. Well, I suppose when I first came into this space, I heard terms like artificial intelligence, and the kinds of images that popped into my head might be the kind of images that pop into other people's heads. They were largely inspired by Hollywood a lot more than they were inspired by maybe the research that's really going on. And for me, working in the space of the future of technology, I've worked really hard at being able to break down what some of these big terms mean to different people in different contexts. So AI is many things. AI is on the one hand, it is the image that you get in your head when you watch Hollywood movies and think about advanced technologies. I think there's one definition of AI that I really like, and that is that AI is a constellation of different technologies that come together in systems. And that can include a constellation of data and sensors and infrastructure and resources, machine learning models, and people and the environment. And these different components or different parts come together. And for me, one of the fun things to do is be able to unpack AI and to tackle each of those areas separately.
You highlighted that New South Wales Health, rightfully so, is probably one of the best systems we got floating around, and the recent crisis is proving that too. How do you see, and we know that New South Wales Health is a very data-rich organization as well, how do you see the future of health transforming whilst being able to adopt these new technologies into clinical and non-clinical practice? Because
I feel like that's a very big question to unpack.
Start somewhere and we'll continue on. We'll see how we go. Yeah.
I mean, one big question for me is, how do we go from asking what does the future of medicine and health look like, and into what do we want the future of medicine and health to look like? Because the technology and the technological systems that we are building now will shape that future, and we are making decisions actively now that will create that. So the future isn't out there and inevitably waiting to happen. We're building it. Yeah. And at the moment, there are very few voices in that conversation. And one of the real challenges is, well, how do you get into that conversation, and what should we be having conversations about? So I mentioned before that we could think about AI as a constellation of technologies or technological components or pieces, and think about each of those separately. We could think from a medical perspective about each of those. So we could think, for example, about data. We know that data are always retrospective, they're always partial, and they're always really contextual. We know that in health until now, the majority of our data sets, and especially our historical data sets, are male, especially some of the big longitudinal data sets out of, say, Europe or defense forces and things like that. We know that most of the experimentation that we have been doing on animals, especially rats and mice, we've largely been using, again, males because the female versions were considered to be too difficult to work with. And I should say, P.S., there is still no mandate or requirement to use equal gender experimental animals. And it was only in 1993 that the National Institutes of Health mandated that clinical trials include women specifically. We also know that data are diverse, that bodies are diverse. We know that past diagnoses aren't always perfect. So if we are having machines learn from data sets from the past, we need to make sure that we don't assume all the data are correct. And we need to think about what's missing. So there are all these questions we can unpack around data. And if we want to build a future where medicine has equitable outcomes for men and women, for example, then thinking about which data sets we use and why is important. We could also ask questions about resources or infrastructure. One of the experiences when we were trying to implement the robotic surgery in South Australia was that the infrastructure of the building couldn't physically host all of the cables and wiring and power sources required for this particular piece of equipment. We can ask questions about machine learning and the kinds of models that we use or the data that we use to train the models. And equally, if we're thinking about building the future, we could be asking questions about the sustainability of those models. So we know that at the moment, machine learning requires a lot of data and a lot of data processing. And we know that at the moment, the tech industry uses a significant amount of electricity and energy. We know that it has a significant carbon footprint. I think last time I checked, if the tech industry were a country, it would be the 5th largest carbon emitter in the world. So it's on the same scale as Japan at the moment. So when we're making decisions about introducing technical systems, we also need to be thinking about what world are we building, not just in terms of what hospital systems are we building or what kind of health system are we building, but what environmental system are we building and how are we influencing that as well.
Yeah, it's very interesting that you highlight pretty much you began by saying that's a difficult question to answer, and then you rapidly proceeded to answer all of it. Because you highlighted the issues with data, definitions, the structures, the infrastructure. Creating that constellation itself is a significant barrier for now. And then the next problem around processing and everything else, which you highlighted as well, and the ethics and other parts of it. We've had a few conversations around the ethics of the use of AI in healthcare. And again, for me, AI is another tool. And if you have trained it on biased data sets and on biased knowledge, that's probably what is going to reciprocate as intelligence. So thanks so much for highlighting those. So how then do you think, do you reverse engineer this process by looking at the future? Or do you just do what we've always done, organically grow? Or is there do you see a method to this?
That's a great question. I would like to say that there is a silver bullet and it would all be very straightforward. Set of questions. Well, this is one of the reasons the 3A Institute exists. We are sitting at the precipice of what's been termed the fourth industrial revolution, which will be characterized by cyber-physical systems or systems which can interact with the environment and learn from them and take in data and respond to the world in physical ways. So the merging of the physical and the digital as well at scale. And this is it represents a significant step change from the third industrial revolution, which, if you follow that particular framing of history, was all about the development and implementation of computers, which we know also disrupted medicine in all sorts of interesting ways. One of the big differences is in the case of computation, we largely have a command and control relationship with it. So we put in some kind of commands or orders, and what results is what we expect it to happen. In the fourth industrial revolution, with sensing systems at scale, we don't see the same kind of command and control responses. We see systems taking in information and, if you like, making decisions or acting in the world in ways that we might not have predicted. Sometimes for the better, sometimes not. And the 3A Institutes, therefore, attempting to build a new branch of engineering, a new set of methodologies, a new set of training programs for people to work in and with these kinds of cyber-physical systems. So one of the things we're actively working on is what would it look like to have some kind of framework to think about the future and think about these systems as we're building them and the kinds of decisions we are making. We have at the moment 6 big questions we're asking, and they are around the A's of the Institute and the I's of the Institute, so 3 A's and 3 I's. The first question is around autonomy. So will the system or parts of it have autonomy as you're building it or implementing it? To what degree will the system be able to make decisions, and where will you have human operators or other constraints built into the system? Which parts of the system are human trained, human operators, doctors, technologists? Which parts aren't? For example, you might have radiographers that are using machine learning techniques to help read scans, but would you want machine learning capabilities to be delivering news to patients? To what extent might you want to check along the way? To what extent might you think about having robotic surgical assistance in some instances? However, having seen robots fold laundry, I don't think I'd want necessarily at this point a robot handling a newborn baby. So there's all sorts of questions around autonomy in the system. I think the next question we are asking as a part of a framework for thinking about emerging technologies is, will the system have agency? Will it be able to act by itself? For example, at the moment, Duke University has just been discussing a new sepsis alert system. And one of the questions that you could ask there is, could that system have agency to begin treating a patient on its own if it identified a risk of sepsis, or would there need to be human decision-making somewhere in the loop? If there are decision-making capabilities, is it subject to laws or requirements? Who ultimately holds the responsibility there? I think that's an important set of questions, especially for medicine. The third set of questions for us is, how will the system be assured? So what are all the safety and ethical and risk, the policing concerns maybe? How do you reassure people as well that they are safe? That's an incredibly important and powerful part of the practice of medicine. We often spend a lot of time thinking about this kind of bucket of assurance-related questions. And at the same time, I think medicine's already a lot more advanced than the tech field in this space, because there were loads of conversations, for example, around ethics and the ethics of research after the Second World War. We see a lot of really excellent, not only ethics frameworks in place, but other frameworks to support good ethical practice. And that's everything from patient reporting pathways to training requirements for different professionals in the system, to checks and balances around new technologies or treatments or pharmaceutical products, all sorts of regulatory systems that sit underneath ensuring people are safe and that the system is safe for people, both individuals and I think for society. And that's an important question as well, as is thinking about both of those. So that's the 3 A's. The 3 I's, the other set of questions we're asking about. The first question is around indicators. So what kind of metrics will you use to determine the success of the system? And I think this kind of starts to speak to your question around, well, do we decide first where we want to be and then figure out how to build to that? To a certain extent, yes, because we want to understand if we're building learning systems, they like being able to know what the goal is or what we're trying to achieve. in which case we need to understand what metrics of success might look like. And at the moment, I think there are real debates about this in medicine, depending on which field you're in, which country you're in, which cultural setting you're in. We use measures from life expectancy to quality of life. What does it mean to have a life well lived? And how would you build a system that supports that, for example? How do we start to think about social determinants that aren't as easily quantified? I know, for example, that there are growing debates around loneliness. And loneliness is not something that is easy to quantify, but we know that it's important. So what are the metrics of success that we would introduce into the system? And how might we adapt them over time? Importantly as well, who's in the conversation about that? It's also something important to think about, and who's making those decisions based on what. 2 final questions we are asking. One is around interfaces. So what interfaces will the system have? How will it interact with the world? What form will it take for patients? We know that medicine is about bodies and care and touch and connection. And those kind of things are often absent when we have conversations about building technical systems. And this is more than just the doctor-patient relationship. Think about a surgical team, for example. In robotic surgery, one of the things that happened when we introduced the surgical system into operating room is rather than having a surgical team around a patient, we required the lead surgeon to be on a console in a different part of the room, so still in the room but in a different part. And the way that technology was introduced into the system totally disrupted the team dynamics, the surgical team dynamics.
That's true about how we use our EMR as well, putting the computer right between us and the patient.
Yeah, absolutely. And the other thing they found was it disrupted training regimes for years to come, because the way that younger surgeons had been learning was observing the older surgeons, but they couldn't do it in this new kind of facility. So the interfaces are really critical. When we look at the Sepsis Watch system that's just been introduced at Duke University, they also had to introduce a lot of new processes and also a lot of new forms to pass between people and operating system checks and all sorts of other things to make up for the lack of communication or the loss of communication between people that had occurred when the technological system was introduced. So that's kind of the 5th set of questions we think is an important one to think about. And the last one is, what's the intent of the system? What are we trying to achieve with it? And how do we determine the boundaries in which we're operating? So we know that there are lots of intents at play in these systems. We know there are commercial intents. We know that there are patient intents. We know that sometimes families don't want what patients want. We know that even within a treating team, the nurses will have different priorities to the doctors. And all of these things matter. So the question is, well, how do you incorporate all of those meaningfully into system design and delivery? And I think for us, another really important set of questions is, what kind of health system do we want in Australia? And that's important because many of the tools and techniques currently being developed are being developed elsewhere in the world. And they will have a set of assumptions in them around how people want health to play out in that particular nation. And I'm not 100% convinced that there is one universal system of health that we could just adopt wholesale. And I'm also not convinced that we or Australians would want everything that, say, is on offer in the US system or the Indian system, for example, or the Chinese system or the British system. There are decisions to make there about what we want our health system to be in future.
That's true.
So that's the 6 questions we're busy working on. You asked for a framework.
No, that's great. And it's good to know that what you've got there, and I'll try to remember those with the 3 A's and 3 AIs covers pretty much any intervention, not just AI for that instance. And, it's really good to see you share your work as well and the passion you have behind it. And be great to keep in touch and see how these progresses, knowing that I'm doing one of the first AI sepsis tools for eHealth New South Wales as well. So we're deploying it. We've built already and we will be deploying it early next year because of the COVID. We pushed it back.
Oh, that's exciting.
Yeah. So did you want to add anything else? Anything you missed out, you think?
I mean, I think something for me that that I was pondering is what are the really key areas for AI or future technologies and in health and medicine.
Yep.
And at the moment, interestingly, the ones that I found most commonly talked about, and I'd be interested in your thoughts on this too, the ones that I found most commonly talked about were ones that were largely disrupted by the third industrial revolution too. So the ones that had been computerized look like they are most ripe for development in terms of next generation technology. So they are around hospital workflow management, medical imaging and diagnostics, therapy planning and decision support, and virtual assistants and language processing. I think there's a really interesting question around virtual assistants and what we consider to be health technologies versus what we consider to be technologies used in health. And I think that's no, go ahead.
Yeah, no, it is an interesting conversation, and I think the definition of health technology versus technology in health, and you can say the same thing about safety of safety through technology and safety of technology in health. It's so, and not many people get that differentiation and use it interchangeably.
Well, I mean, wearables is an interesting example of that, right? Yeah. Where wearables many of us are using every day to monitor all sorts of biometric biological processes. Yeah. But because they're classified as or they're not classified as a health technology, they're not required to have any forms of health-related checks or balances on them. Yeah. However, if they were classified as a health technology, that would be a different concern. I think where that becomes an interesting question is if we start to use data from wearables to deliver medical treatment or make clinical decisions.
That's when they'll have to meet that standard. The other piece of work on this, which is interesting to look at, is as we move from an interrupted data system to a seamless, continuous data monitoring, what needs to be recorded and what needs to be stored. Because as you talked about processing, you would then have the storage capacity. Do we keep all the reams of data, 24-hour monitoring, or we still only collect hourly monitors? But anyway, those are long-term conversations to be had. I'd be happy to catch up with you again later on about it. But
absolutely. Yeah. Well, there's some questions there as well around what can you sense and why? What are the sensors doing in the system? Sensory information is also critical for surgeons to make judgment calls. So if they're no longer taking that information in, for example, then where are they getting that information from to be able to make their decisions? Yeah. What do we decide to collect information about and why? And I think there's some interesting questions there. For me, two fields that aren't talked about a lot yet, but I think I can see on the horizon. One is ambient sensing, which is some work that's just coming out of the US now around being able to sense in completely different ways. Because I think one assumption that's commonly made in this space, which is complicated, is the assumption that bodies are like machines and that machines are like bodies. Yeah. And we know that bodies are much more variable than machines. And they don't conform to any of the rules that machines conform to. And equally, machines aren't bodies. We don't just need to have two eyes at the front, for example. They're not just about hearing. In fact, they can pick up all sorts of other material in the environment. So I think disrupting that assumption could be really important moving forwards. And I think the other one for me that's really important is how education is, the clinical education, medical education, and health education are both going to be disrupted or need to be disrupted by these new systems, and equally how these systems will disrupt the education process. And I think we're starting to see more and more case studies or examples that are all showing something very similar, whether it's the robotic surgery example, whether it's the Duke University Sepsis Watch program. The biggest challenges there were the people challenges and the relationships between people on teams that were disrupted when new pieces of technology were introduced and new work practices were introduced. I think being able to not only ensure that medical practitioners or people throughout the health system have a critical understanding of the tech that is around them. That don't necessarily means they need to be able to explain it, but to be able to ask critical questions when it matters is important. But equally, the human relationships training and support is something I think we'll have to continue to work on. And in fact, the Duke University group called it repair work, because they had to repair so many relationships and rebuild them following these processes of disruption. And I think there's something important there to think about where education and workforce change is concerned.
Yeah, now there are suitable challenges to look at because disruption is everywhere, and it's not about, like you highlighted, just plugging a technology and dropping it in. It's not a plug and play, and it will disrupt a lot of. And at the end of all of it, being able to deliver a patient-centered an experience that they long for, and how do we capture all of that? I think it's an incredible journey we are on, and it'll be great to catch up with you again in the future.
Would love that. Yeah. Thank you.
Thank you so much. So that's all we have time for this episode. Thanks for joining me on the show. If you enjoyed the podcast, make sure to like, share, and subscribe on whatever platform you are on right now.